In this module, we'll be reviewing hand x-rays as well as fingers. This will include the AP, lateral, and oblique views. When doing an AP or PA of the hand, ideally you'll have the patient sitting adjacent to the table. You'll place a cassette underneath them. Yes, we'll be doing this 40-inch tabletop. The x-ray tube is 40 inches above the cassette itself. The hand is placed pronated flush against the cassette. Now you can do this supinated, but more ideally it's more comfortable for the patient and more easily accessible. So I highly recommend a prone position, a PA version of your AP/PA view of the hand. You'll want to center your crosshairs straight down on the middle knuckle. Open your collimators up to make sure that you include all fingers and the proximal or the distal radius ulna, just a portion of the wrist as well. You want to be comprehensive with how much you're providing to the doctor so they'll have adequate information. Your technique will be 2 mass at 52 kVp. Here's an evaluation of the PA hand. You'll look at the hand as if it's in anatomical position. So if you're looking at a view box or a digital readout, you'll hang it very much like this, in anatomical position, as if a person is holding their hand up in the air and you're looking at them from the front. So this is the left hand. You see the fingers are spread out evenly. It's a well positioned. You can see just a couple of inches down below the wrist, which is ideal. We can see the carpals easily in profile, and we can see some joint interspaces as well. Off to the left hand side is a very common problem. People will burn out the x-ray because you might be able to see the carpals and the joint space in here, but they'll actually burn out the distal fingers, and that's not going to work. You have to make sure that you not only see all the bones in the wrist, but you want to see them up in the hand as well. So you've got to find a balance to where you can have a good visualization of the entire appendage. Also, off to the right hand side, a light or underpenetrated image is just as deleterious to the diagnostic process as anything, because you can't see the bony processes, you can't see the bony patterns as well, or the articular surfaces in the wrist itself. You might be able to see the fingers a little bit, but this will not diagnose any type of minor nuances at all. So this is your game plan. This is what you're shooting for here in the middle. A lateral hand is very similar to the AP in the sense that the patient simply flips their wrist upwards and they're going to put their hand in a karate chop. We're still tabletop. You're going to focus your crosshairs on the knuckle line, but right along the axis of the fingers. Your thumb is kind of dragged away, abducted away from the other fingers. So all the fingers are in profile except for the thumb, which is in PA position. You can use 2 mass at 54 kVp for this exposure. One thing of note, you want to make sure that your fingers fit completely on the cassette. It looks like this patient is borderline getting his fingers cut off on the edge of the film here. I might pull the hand back a little bit just to make sure that I include all of the fingers in the image. And here's a profile lateral x-ray. Notice I've got arrows pointing at each one of the digits. We can see them all clearly in this x-ray. It's beautiful. But you can't see, or you want to make sure that you see the proximal portion of the hand as well. You've got the metacarpals here, and we can see some carpals in profile. You've got your thumb in PA position. So we can visualize the entire hand down to the wrist very well in this image. It can sometimes be pretty easy if someone's got fat hands and skinny fingers kind of thing. You can burn out the fingers as seen here. We saw that on the AP as well. And look at this. This is very common when you underpenetrate the hand, but you'll still see the ends of the fingers. So you're going to want to play with your techniques. Even though I gave you a baseline technique, you're going to want to play with your techniques so you can achieve this type of hand in the middle on every shot. And there's our thumb in its AP position. Now, for the oblique hand, this is neither an AP or PA or a lateral. We're rotating the hand so that we can see the distal metacarpals, which is the knuckles, the knuckle area, better than we can on the lateral or the AP, because there's some subtle nuances of the anatomy that we want to make sure we check out before diagnosing a patient. So you have the patient with his hand cocked up just a little bit, about 45 degrees, maybe 35 degrees. And if they can hold this, you can center right there in the middle of the hand on the knuckle. Make sure you include all the fingers and the wrist as well. You can also, if you choose to, a lot of people do this, is have the patient put their hand in an OK position, their index finger and their thumb together. You bend the fingers so that it kind of angles the whole hand up in an up 45 degree angle, and that's perfectly acceptable. You can use somewhere in the neighborhood of 2 Mass at 54 kVp for this exposure. Here's what it looks like on x-ray. We are hanging it in anatomical position, but look at those, whereas we saw kind of a rounded edge to our distal metacarpals before, now we see it kind of cocked to the side. You see these balls in their true shape in relation to the rest of the digit here. And that's a much better profile that we're able to at least get a second guess, a second look at the articulations and the knuckles here. Also, we've got a better view of the carpals as well. Now, notice I said the knuckles. You can see here, that's exactly where the knuckles are. You can see the soft tissue coming across here. So when you're looking at the hand, this is about the only part you're seeing outside when you're not looking at x-rays. So oftentimes people want to take x-rays of the fingers and they'll only include this part, but now you know the fingers are always included all the way down to the carpals. And as stated before, the film is simply rotated, the hand is rotated so that it's roughly at a 45 degree angle. Now, when we're talking about fingers, I just want to reiterate to you, just so you make sure, when someone orders finger x-rays, you don't want to take an x-ray of the entire hand. It looks like you are, but all we're saying is you want to collimate up beyond the wrist. Make sure you cut the wrist off and you're including your digits all the way down. You've got 3 layers of digits. It goes all the way down to here where it articulates with the carpals, but you want to make sure you include each one of these ends of the metacarpals as they come down into the wrist area. So, as a reminder, where you see the fingers start on the hand is not where you're shooting examinations. You get a finger x-ray, you want to make sure you include all the way down to the closest portions of the hand, and this is what it looks like. AP lateral, AP oblique and a lateral. Now, what about the thumb? The thumb x-ray, if you're doing a lateral thumb, can you look at any of these x-rays and tell if you've got a thumb in profile? This may be a slightly profiled thumb, but again, it's not a complete lateral. We want to make sure this is more of an oblique thumb, and this is not. This is still kind of an oblique thumb as well. So we don't have a lateral thumb, even though we could do a bunch of views of all the fingers. We won't end up with a lateral thumb. So you have to kind of specialize and do a special film for a side shot of the thumb. So you'll pull the thumb off to the side. You'll have the patient rest their hand on the cassette. You'll center close to around where the knuckle region is, but you'll collimate right down to the thumb and make sure you position it so it's sideways and you get the entire thumb in profile. And of course, this is what it looks like on x-ray. So that concludes our review of both the hands and the fingers.